Well, I certainly want to welcome everybody to this week's installation of the 988 call. And we look forward to having exciting conversations today. We're going to take lessons from poison control. We're going to hear from Dr. Marsha Ford and be able to look back at 70 years of what's transpired with poison control. And Dr. Ford has the task of boiling 70 years down to 15 minutes for us to be able to look at what's transpired as it relates and draw parallels in terms of looking at poison control and thinking about what we're facing in terms of rolling out 988, which, as a reminder, is 87 days from today. Next slide. This slide hasn't changed too much, but we continue to document all the national organizations that participate in these calls, along with states and those individuals that are participating. We still have the highest point in terms of numbers of individuals, being February 2nd with 404 individuals. David has challenged me to try and grow our Medicaid participation out there. So if you look at the map and you're a Medicaid individual from a state that's not colored in red, we ask that you go ahead and identify yourself so that we can add you to the map, but we continue to look and grow our presence. Also, we've got a number of other countries that are joining the call, so excited about that. Next slide. We continue to make all of the resources available. So if you just look and go to the Crisis Talk page, you'll see all the different previous conversations that have had, all of the information that's been made available, the resources. So continue to go back and look if you're not able to join the calls. We were talking earlier about individuals that have been with us every week, but we know not everybody can do that. Just highlighting Wellbeing Trust works with the CEO Alliance for Mental Health. We're making resources available together in anticipation of the 988 rollout. So wanted to make sure everybody had seen this. And then also 988 rollout continues to be highlighted in the media. There was an article that came out just a couple of weeks ago in Slate. There was another one that came out recently from Pop Sugar, a weekly publication. So we're continuing to see a large amount of interest in terms of 988 rollout, highlighting what states are doing, looking at what's happening within individual communities in anticipation of this. So as we get closer and closer, we expect to see more and more communication and media and different types of articles that will be out there. And certainly once 988 goes live, we would expect to see that as well. Well, last week in our conversation, Dr. Pat Deegan had the quote, "There are always two experts in the room in crisis care." And it was highlighted at that time that that would be the quote of the week next week, and it is. So we pulled that out and felt that was important to highlight from the conversation that occurred last week. And again, if you weren't able to join us, you can go back and look at the resources and look at last week's call. Next slide. So that takes us to our featured presentation, and we have Dr. Marsha Ford with us, and she is the founder and past director. And so, Dr. Ford, I'm going to turn it over to you to walk us through the history of the poison control system.
Thank you. And thanks for having me today. I'm going to give y'all a very broad stroke overview of the Poison Center system, a little history and how it has developed where we are today. And hopefully you'll pick up some ideas for your 988 system. Next slide. A little history. The first Poison Center opened in Chicago in 1953. Next year, 54, the second center opened in North Carolina at Duke. By 1978, there were 661 poison centers. A lot of these poison centers were the result of hospitals saying, good PR here. I'm going to put a phone line ringing into the pharmacy in the hospital, and the pharmacist will answer the calls in between filling hospital orders. Well, today there are 55 centers. So what happened? Well, what happened was the American Association of Poison Control Centers developed guidelines for regional certification. These started in the 1980s and they continue to evolve. And they said, okay, you have to meet these certain criteria in order to be certified. Well, when that happened, the hospitals realized, first of all, if they weren't going to meet those standards, they had liability issues. And also the financials were no longer making sense. So hence 55 centers today. Next slide. And here we are. The red dots signify the centers that serve the states in which they are located. Some states with large populations have more than one center. The blue dots signify centers that don't have a center within their state, but instead contract with one of the red dot centers for services. Next slide. So let me tell you a little bit about our national organization, the AAPCC. It's a self-governing body of poison centers. It was established in 1958. All of the officers, board of director members, committees, work groups, et cetera, are manned or womaned by volunteers from the member centers. We do have professional staff. And they established standards for regional certification. And I'm going to touch upon a number of these subsequently, but I just want to say that staff training and certification has been one of the things that has really made a difference. Staff have to meet certain training go through certain training, and then they have to take a certification exam. This is a national examination. If they pass that exam, they go from being a specialist in poison information, a SPY, to a certified SPY, which is a C-SPY. And this national examination is now overseen by psychometricians to make sure that the exam is valid. And having this training has really, I think, improved the quality and evenness of the advice that we give. Next slide. So what are the important things that AAPCC has done through the years? I'm going to talk a lot more about what's going on today. But first of all, there was federal legislation that not only established and funded the nationwide toll-free number, but also provided some financial stabilization for the member centers. We get monies every year from the federal government that fund about 15 to 20% of center budgets. It also, under its guidance, the national database was created, the National Poison Data System. And this provided standard data points to be collected and also standard data definitions. And the result was to enable the monitoring of trends in poisonings, to monitor adverse drug events. FDA gets our data all the time to help augment their data, and to identify hazardous products, especially the hazards of new products coming on the market. Next slide. So when a call comes in, there are two main groups that call us, the public and healthcare providers. So when a call comes in, specialist figures out what type of caller, and then figures out what the exposure is, the toxicants involved, the details of the exposure, what's the status of the patient right now. And then the specialist looks up the substance in a database called PoisonDex that is owned by IBM. PoisonDex contains over 1 million drugs, chemicals, gases, natural hazards like snakes, etc. And they're able to look it up and look up expected effects. Also, there are over 850 management guidelines that are in PoisonDex that the specialist will have access to. They may also consult. All centers are required to have 24/7, 365 backup from a toxicologist who is either a physician or a PharmD. In a few cases, then we give advice to the caller. In a few cases, sometimes we have to call EMS directly and dispatch a unit, and we have done that. Then the data are entered into our database, and more about that in a minute. But I will here to tell you that about 2/3 of our cases, and in some centers more, are managed at the site of the exposure with no further medical care given by the rest of the healthcare system. We do follow-up calls as necessary. Some centers are now using texts to do the follow-ups. And I will tell you that if we do refer a patient into the hospital, we call ahead, the specialist calls ahead to the nurse at triage gives them the details, tells them what's coming, and gives some initial management advice. And then we follow up those calls with multiple follow-up calls. Next slide. Call from a healthcare professional. A lot of the steps are the same, but you may also have to, we may also have to get lab values and find out treatments that have already been given. Here is where the medical toxicologist may have more involvement, including speaking directly with the physician or nurse taking care of the patient. And then we do make, as I said before, multiple follow-up calls on hospital cases until we know the final disposition of the patient. Next slide. So here are a couple of screenshots I grabbed from one of the programs that's used for data entry. This is not a vision test for y'all. You don't have to be able to read the fine print. I just want you to be able to understand the granularity of the data that we collect and keep on these callers, including on the left, demographics of the patient, how's the patient doing, sign, clinical effects, what's the poison, why did this happen, was this a self-harm attempt, notes, type notes, individual notes on the left-hand side, and then at the very bottom, very important, medical outcomes and management sites. And that data has proven invaluable to poison centers to make the case of how many patients we're managing at home, how well they're doing, and how we help augment the healthcare system in a very cost-effective way. The screen on the right is a sample screen of clinical effects that can be coded. You see cardiovascular and GI systems. And again, we make big use of a lot of drop-down menus to make this a very quickly populated database. Next slide. All cases from poison centers are automatically uploaded to the National Poison Data System. This is de-identified data. The upload or the refresh of cases that have had additional data added to them occurs on average every 8 minutes. Nationally, and there are algorithms functioning in the background to try to detect emerging events in near real time. Currently, there are over 74 million cases of exposures in this database. And this database is used for research by poison centers, public health, regulatory agencies, and industry uses this a lot to look at their own products. Next slide. When we finally got the nationwide number, this really provided a lot of cohesion for poison centers and really increased the ability of our communication system to be redundant, because we can quickly offload calls to other poison centers with whom we have prior arrangements. If we go down, our communication system goes down. If there's a weather incident, if all of a sudden we're getting a surge of calls, let's say in North Carolina about something, we can in routine staff meetings, we can offload those calls very easily. As I mentioned, we interact a lot with other people in the healthcare system, but we also interact with our own poison centers. As an example, misdirected calls. Somebody calls it from Texas, and they wind up in North Carolina. We answer it, we do some initial screening, and then we do a hot transfer back to the appropriate Texas poison center. We keep digital records of all of our calls, and in North Carolina for 21 years, because in North Carolina, the statute of limitations for malpractice against a child does not expire until that child reaches 21 years of age. Work from home. We started doing this in North Carolina in 2003. And in 2003, there was no off-the-box programs, off-the-shelf programs. We had to create everything. But now today, with all the work from home and telehealth, it's much easier. I think it's a great way to, a great thing to do. I think that in North Carolina, I allowed my certified specialist to work up to 50% of their shifts from home. It was great for weather-related incidents. And the reason to use it all the time is so that when you really need it, it's working and you know that it's working. Next slide. Poison prevention has also evolved. Initially, it was really more about just getting the word out. Hey, we're here. Here's our number. Give us a call. We did a little stuff about how to safely store drugs and chemicals. But today with social media, we are able to do so much in terms of downloadable brochures, in terms of all sorts of, for instance, the illustration at the top of the page, to create videos that are targeted to small at-risk populations, such as this one, aimed really at preteens. Regulatory efforts, we've done a lot with packaging and repackaging of products. We've also participated in recalls, and just a quick story about in 2007, there was a toy, Aquadots. It was slated to be the Christmas toy of the year. In North Carolina, in Charlotte, we had a 3-year-old child who ingested some of these and then went into a coma. We subsequently figured out that the reason the kid had gone into the coma was because the solvent used to manufacture these dots had a solvent in it that in the body was converted to GHB, the date rape drug. So we filed a report with the Consumer Product Safety Commission, and 3 days later, 4 million of these toys were pulled from the shelves and not sold at Christmas. So that is a way in which we made a major impact on public health. Next slide. Acknowledging that a lot of people don't like to make a phone call anymore. They like to go to the internet. Several people in poison control around the country began creating a web-based product that is now available on the web and also via app that can be downloaded in the app stores. And here, the person enters some data about the exposure, enters some data about possible symptoms, checks a little box that says no self-harm intended, and then hits the button, and evidence-based algorithms make one of 3 determinations: can stay at home, in which case the person is told, here's some stuff about what you got exposed to, and here's some stuff about what might happen. They are told to call the national number, 800-222-1222, or they're told to go to the emergency department now. They are able to keep about 70% of their people from not going any further than this app. And last year they took about 156,000 of these cases online. And again, another way of being very forward thinking and proactive and showing that we have value in the healthcare system. Next slide. So just to sort of finish up, I just wanted to emphasize a couple of things. And first is that we work with all facets of the healthcare system, with emergency medical services, emergency departments, hospitals, public health. We prevent unnecessary use of some of these areas. And we, again, sometimes assist in non-healthcare facility management of patients. Example, EMS goes out, they get on site, they don't think the patient needs to come in. It's a toxin. They call us. We go through our screening, and then we help them make the decision to leave the patient on site or to go ahead and transport. Prior to that, they always transported everybody. And the last thing is that poison centers serve as venues for training residents, especially emergency medicine residents, medical students, and fellows in medical toxicology, both physicians and PharmDs. Next slide. Here are a few references if you want to delve further into how the system has developed. Thank you very much for having me.
Thank you, Dr. Ford. And your presentation generated a lot of questions. So I'm going to ask you a few, and then I know we've got a couple of individuals that would like to respond to your presentation.
Sure.
So the first is, how are calls distributed in terms of, are they based on area code, or what's the algorithm that's used there for call distribution?
Right now, it's still based on area code, and that's a big problem because obviously I live in Atlanta now, but I have a North Carolina area code. Poison centers are still trying to work with the various providers of the major cellular service providers to route the calls based on billing address rather than area code. But that is a problem.
Yeah, no, I think everybody's wrestling with that one. How do you deal with?
We should join forces because
Yes, there's an opportunity there,
there's
right?
an opportunity, right?
What do you do in instances where you may be talking to an individual that's uncertain in terms of what might have been ingested?
Well, it would depend. I mean, and of course we do have people that lie to us, but don't say that, but they do. But I think what we do is we try to take a look at the situation. Were they uncertain because they were in the kitchen and maybe they spilled some acid on themselves and they're not very symptomatic, but they can't find the bottle. In that case, we might go ahead and send them in just to get them checked. I can't give you a one size fits all answer. Some of it is also just the sense of the specialist taking the call that something's not quite right about the story. In which
so you got to sort of just work through it in terms of trying to decipher what happened, and if not, then you send them in. Sounds like.
Right.
What do you do with individuals that might be experiencing a drug overdose?
In what sense? You mean in those cases? If there's anybody on site, we would advise them to call 911 if it's a drug overdose, because there's so many different things that don't have immediate effects. Mm-hmm. If there's nobody on site, this may be a time when we actually dispatch EMS. If there's and the person does not seem coherent enough or is not willing to call.
Thank you.
Themselves.
And then what about standards in terms of response times for these different poison centers in terms of either, the calls will be answered so quickly or the handle time? Are there standards as part of your accreditation?
There were, and I don't run my own center anymore. So I can't give you a specific answer as to whether there were some standards, but it's an average. And there were also standards about dropped calls. Mm-hmm. And it was something like if a call was dropped within the first minute, then those didn't count. But anything after that, they counted. There were standards. Now, whether they're still there and the precise standards, I can't tell you. But using the digital phone system, that's another benefit of these systems, is you have all that data that you can mine.
We have another question here that asks about at-risk populations and sort of what efforts were done by the poison centers in terms of identifying strategies for at-risk populations.
It's really more a matter of looking at the data. You segment by population, by age, or you segment by geographic region, or however you want to segment it. And then you begin to look at what are the most common products that these folks are having problems with. For example, it's almost always analgesics is the number one category that's problematic. Number two are household products. During the time of COVID, it got to be sanitizing agents and that sort of thing. Anyhow, you begin to dig down into the data, to identify areas. And then you began to, we did some stuff where we brought in focus groups to try to help us identify what interventions might work. And then we designed our social outreach based on that.
Excellent. Thank you so much. We've used the poison centers on multiple occasions, didn't even think about all the underlying great data infrastructure that you've developed over the years. Very impressive in terms of all the different analytics and the ability to really aggregate data and see what's going on in terms of trends and being able to manage all that. It's incredibly impressive in what you all have done.
Well, we have
years.
grown with the technology. I mean, that's the bottom line.
Sure.
You know, we couldn't do this 40 years ago. The technology wasn't there, but now the technology is, and now the expertise in analytics is there and developing.
Yep, very much so. So we have with us also Dr. Schneider and Dr. Allen to be able to add their insight as it relates to this topic. So Dr. Schneider, do you want to lead?
Yeah, I'll take over with my good friend Michael. And first, Marsha, thank you. Marsha is a very, very good friend, and she did a wonderful job. And she's really dedicated her life to poison centers and poison information. Someone asked a question about how come this isn't called poison control anymore, and the answer is it's really about poison information. And they changed their name some time ago. And I've been a guest or listened to this jam for some time and been involved in this discussion. So I think there's a couple of points that Marsha made that I want to emphasize, because I think they were critical in the evolution and the acceptance of poison information, and particularly the acceptance of poison information centers with physicians. One of them is that when they made the training standard, when you know you were going to call a poison center and you were going to get someone who knew what was going on. And if they didn't know what was going on, they would always send you to the next person. So that's having a standardized protocols and standardized training, standardized operation. So one poison center looks a lot like another one. There are some minor changes, but you get the same product out of them. The second was physician involvement. I think it made a real difference when there was a toxicologist on call and you had the thought that I could talk to that person. That doesn't have to be 55, but have a toxicologist on call. And the other piece is when they integrated it with the residency. So all the residents knew about the poison center and had some information. And when they went out, they were like little disciples. And they were like, let's call the poison center. And they're like, who's the poison center? And that just changed that whole thing. The other big one is follow-up. And I know that's an issue that in the standard way that you guys think about things may or may not work with some of your suicide lines, but the follow-up, understanding what happened, not only was important to get buy-in from the community and buy-in from the physician community, but also laid the groundwork for the federal funding, for the support the poison centers got over the years, for their acceptance and their ability to say, hey, we're cost effective. Hey, we've done good for the public. Hey, look at all of this stuff we've done. And that follow-up occurs, I think, a lot more often than Marsha sort of alluded to. They follow up most of the calls with just another call that says, hey, you called yesterday because your kid ate a crayon. Can I send you some material about how to keep your kid from eating something that's more dangerous, that type of stuff. So that's my big take homes for you guys of how you could sort of go from the, this is kind of like the African nations to start off with, we started off with like a telephone or a telegraph, and now we have cell phones and they just jumped right to the cell phones. Michael, what did you hear?
Oh, well, first, let me say, Marsha, you and I graduated from the same class at MUSC, so it's great to see you again.
It's good to see you too.
Yeah, so Sandy, this is part of a long-running conversation that you and I have had, and I think what I take away from it, poison centers have been in the conversation about 988 since I want to say 4 years or so ago, and the idea, the central concept is there is a group with expertise who has the knowledge that people need to help them in a particular situation. And the Poison Center takes that expertise where it's needed. And so that could be where people are in their homes. It could be to doctors in emergency rooms. I know I've been a customer managing people with overdoses at the hospital and have worked with toxicology fellows and with the Poison Center to manage those patients through the medical part of the overdose and into the mental health part of the overdose. And I know, Sandy, one of the things that you've been concerned about is that you are excited to see us improve the detection of suicidal people in emergency departments, but you need to know where the expertise to assess those people is going to come from in order to have something to do. And here's a fun fact: 72% of suicidal people in emergency departments get admitted to psychiatric hospitals. Now, that's probably not necessary, but that's because of this problem of not having the expertise available in the emergency department in order to make the call about whether this person can be managed in the community or not. And so I think the Poison Center model teaches us something about how to take expertise in a central location, deliver it to the people who need it, and make better decisions about the care of those patients. Imagine if everybody in the country who ingested anything had to go to the hospital and get admitted. You know, we would be completely overwhelmed by that. And so what Poison Centers allow us to do is to sort of determine how serious is this problem? Can it be managed at home? Does it need to go to the hospital? If the person's at the hospital, are they going to need to be admitted to the hospital? And so it helps the entire system of care to understand and provide the appropriate level of care for people exposed to toxins. So I think if we could take that wisdom and apply it to mental health crises, then it would be fantastic. We could do that leapfrog thing that Sandy is talking about and go straight to the cell phone instead of having to go back to the rotary dial.
So Michael, you and I've had this conversation, but I don't think the rest of the 988 is, but you know, I'm an emergency doc. My knowledge of psychiatry is pretty primitive. I don't have the knowledge that you do and many of the other psychiatrists and probably many of the people on the call do. So when I see when a patient comes in who is suicidal, I have to make that decision. Am I going to send them home or admit them? And one of the easiest thing is to admit them because my liability goes away, etc. But I would love to send more of them home, but I don't have that follow-up. So if I see a patient that has eaten mushrooms, and I don't know what mushrooms they've had, and I know that there is a potential that that person could get sick 2, 3, 4, 5 days from now, I might be able to say to the call up a poison center and say, you know, call that person back, because I'm pretty sure they didn't eat any mushroom that was critical, but you know, maybe you could get them back in to get their blood drawn, or maybe you can get them, you can see if they've had any nausea or vomiting, and then, you know, I know what to do. But there's no reason they have to come to the ED for me to watch them to see if they vomit, okay? Because they can go home. And I have a level of comfort there that somebody's going to follow them. I don't have that level of comfort when I send a patient home who came in and said, you know, I'm thinking of killing myself. I don't have a plan, but I'm thinking of killing myself. And I'm, you know, and then I say, okay, go home. You can go home. But I don't have the next step. Oh, and there's Richard. I've had this conversation.
He's got his hand raised.
Yeah, go ahead, Richard.
Can I raise mine? I just want to build on what Sandy just said, which is, and Michael also, that poison centers do more follow-up calls than I alluded to. And we've also been known to follow up after the patient goes home from the hospital, after the patient goes home from the emergency department. And on occasion, we've sent the patient back if we thought that was necessary. I also practiced emergency medicine, and I echo Michael's comments that really it would be great, and Sandy's too, it would be great if emergency physicians had access to the mental health expertise that we don't necessarily have. We're much better about screening these folks for medical problems. And then after that, it's a little dicey for us, okay? So I think those are great thoughts about how the model that we have might help the model that you're building.
Richard?
Yeah, thank you. I was just going to respond to Sandy's important point about, being able to rely on the availability of follow-up to be able to say with confidence that this person's going to be followed up. They're going to get a contact, a phone call, an appointment, ideally, within the next day or two. And she's absolutely, right about that. And I just wanted to make sure that people were aware that as part of the White House's released strategy on military and veteran suicide prevention, it basically asks for the federal departments, HHS, VA, DOD, Department of Transportation, and others, to work together on a feasibility analysis and implementation plan around improving screening, safety planning, and follow-up in emergency departments, emergency medical services, et cetera, around the country. So I've been asked to co-lead that effort. So we may well be coming back to this group to try to get, feedback on that. Michael has been engaged in helping to promote exactly that kind of follow-up across emergency departments in the state of Colorado. This is one of our best opportunities to move, to move that forward. And, a lot of really important work has been focused on 988 and how to prevent people who don't need to go to emergency departments from having to go there in the first place. But there, of course, will always be lots of people at risk for suicide going to emergency departments. And that ability to make sure that there is follow-up rapidly afterward in a reliable way is a key priority that we will be working hard on. And I'm sure we'll be reaching out to you, Sandy, for additional information from your perspective.
Yeah, and I think we've had this conversation, I think Michael and Richard and I had it several years ago around universal screening. And one of the comments I had around universal screening is great. Now I just, if I universally screen, I've actually just caused myself a problem, because now I've got to deal with those patients and I have no options for them. I have only two options: send them home with nothing, okay, or admit them, which seems to be a little bit rash in many cases. And so, if we had a system, and I've said this before, if we had a system that I could do an easy handoff of these patients, the ones I don't want to send home because I don't know what the next step is going to be. If I knew someone was going to catch them when I sent them home, then I would be more apt to both send more people home and more apt to screen more readily.
So our time is up. We could spend the whole hour on this conversation, and certainly appreciate Dr. Ford, you taking the time and drawing the parallels between the experiences that the poison centers have been through over the last 70 years and where we're headed in terms of a system around 988. And thank you, Dr. Allen, Dr. Schneider, for your thoughtful remarks in response to the presentation. But with that, we need to move on. Dr. Ford, if you could look at the chat, there was a conversation that was going on as it relates to doing this type of work and doing it from home, and whether or not you've created standards around how that might be done for staff that might be working from home and doing this type of work. So if you could
I'll take a look at those.
take a look at that, that would be great. That's just another way to get our response to some of those questions that are floating out there. Really appreciate it and appreciate the great presentation. So with that, we're going to move on to this week's trivia question. And so we have Dr. Allen, who's going to participate with Bev Marquez. So this week's question: the National Suicide Hotline Designation Act of 2020 required SAMHSA and the VA to submit reports on 988, including supports for high-risk populations. What were the high-risk populations identified by the Act? And those are your choices. So what are your thoughts, Dr. Allen, Bev?
Well, I know A is correct. That's for sure. Bev, do you recognize any of the others?
Well, I think that it would be all of the above,
You can certainly make that argument.
because I think B for sure, certainly in the statistics that were given as rationale for the act, I believe that each of these populations were referenced. So I would say D, Dr. Allen.
I can go with that.
All right. And if you looked in the chat, there was clear consensus that D was the answer as well. And here's our results. So the vast majority of those on the call are saying D, and in fact, D is our answer. So congratulations. Well done.
Yay.
Yay.
Thank you.
Thank you
Thanks,
for
Dr. Allen. High
participating.
five.
Hey, good to see you.
Excellent. All right. And with that, we'll move on to the next segment in our call. And so, Stephanie, I'm going to turn it over to you. And this week we're highlighting Lindsay. Hey, Lindsay, welcome to Crisis Talk and the Jam.
Thanks, Tom. Yeah, Lindsay, if you're on the call, you made several key suggestions in the article, including SAMHSA and CMS coming together to talk to Medicaid leaders and also behavioral health agency leaders about Medicaid guidance. Can you talk a little bit about that?
Yeah, and this is a piece that is really important to me and that I've been working on throughout my time working in the Medicaid program, of that collaboration between Medicaid and behavioral health. And that collaboration kind of extends to the federal level, and looking for closer partnership between CMS and SAMHSA as key leaders in this effort to build out the crisis continuum. And I would say there's three reasons why I think that coordination between CMS and SAMHSA is particularly important. First is that it signals kind of the importance and the value of partnership between Medicaid and behavioral health leaders across the country. Second, I think it helps to align, what the best practices are with what can be paid for under federal rules, right? So making sure that when SAMHSA is putting out guidelines and best practices, there are pathways in Medicaid and clear authorities to be able to support and do some of those things. And then third, I think it can really maximize the technical assistance and support for states when we see SAMHSA and CMS together at the table, kind of bringing both sets of content expertise.
And you mentioned the firehouse model, and I thought that was really important for state leaders to pay attention to, sort of this difference in terms of lens and how it's going to take some creative thinking and choosing, they have a common goal, but being able to implement and do that creatively. Can you talk a little bit about those distinctions in terms of the firehouse model?
Yeah, I think it's just important to remember that, Medicaid is designed to pay for services, clinical services, right? An individual goes to their doctor and then the doctor can bill Medicaid for those services. But when we're talking about sort of a common good, right? A call line that anybody can call regardless of who the payer is, or a mobile crisis team that responds regardless of who the payer is. That's where it can be a little bit trickier for Medicaid, and it requires some creative thinking, some of the collaboration that I talked about with Stephanie in this article.
Thank you, Lindsay.
Thanks.
Lindsay, great to have you on again. I think you've had the opportunity to host a couple of times as well. So good to see you again on the Crisis Jam.
Likewise.
Stephanie, thanks for the update. Great article. With that, we're going to turn it over to James from SAMHSA for the SAMHSA update.
Yeah, good afternoon, everyone, and thank you. So go ahead and go to the next slide. So we're hopefully many of you had seen yesterday, but we're very excited that we're able to finally release the awards for the 988 State and Territory Grant Program for SAMHSA. This effort came out to a head yesterday, and that notice was sent out by our Assistant Secretary for Mental Health, Dr. Miriam Delphin-Rittman, talking about how critical the preparation and transition to 988 is, and also the federal and national stakeholders, but also the states and territories as critical partners in this effort. So if you have not had an opportunity to check out the release itself, please do go to samhsa.gov, and at the top header page that scrolls, you'll see a link to that announcement. Embedded in that announcement is the awards for the individual states, which I'll get to in 1 second. Can you go to the next slide, please? Did just want to share a little bit of the outcomes from the notice of award. We were able to release 54 state and territory grants for the 988. There were 2 states that did not submit, Alaska and Rhode Island, but I'm pleased to report that they've agreed to work in a parallel process for 988 readiness and response, and will be engaged in a similar fashion as to the grantees. This is really a monumental opportunity, in our opinion, for significant development and response, as well in territories. All 5 of our territories were awarded, and 3 of which had not had previous center engagement. So that's a true test to the activation of a 988 and where it will be available, and the buildup of those services therein. It also required some enhanced coordination and support for in-state tribal response. Prioritizing collaboration and support with tribes to ensure effective response and linkage to local services, and also training for all crisis center staff that specifically address the needs of tribes within their state. So SAMHSA will be following those very closely through our grant project officers to make sure that those are achieved, and working in coordination with those tribes and through the tribes, through the states and territories. Here is a link, if you haven't been able to do so, to the awards themselves. So please do take a look at this. It's on SAMHSA's website. If you actually hit the little plus arrow, you'll actually see the abstract of each state or territory. It'll give you a snapshot of what their focus is with the amount of funding that they'll receive over the 2-year period. Next slide. And then I did want to also highlight something else that's really been built out this last month. These are the partner toolkit assets that are available on SAMHSA's website. A few things, if you go and click on the toolkit, that you'll have access to: updated fact sheets, key messages, FAQs, newsletter, the logo and the branding guidance, how to use that moving forward. Also a sample 988 deck and a radio PSA script. So please do. We are going to continue adding products to this. We are requesting individuals take a look, and if you're looking at current communication or marketing campaigns, to align it with the guidance that's put under the partner toolkit. If you have a feedback on those, please don't hesitate to reach out and let us know. And last slide for me, and then I'll turn it over to Richard or any of the other 988 team members. Wanted to make sure you are aware, and Nashville may talk a little bit about this in a second, but we were very excited to work with a lot of key external stakeholders, many of you possibly on this call today, for an assessment of operational readiness and development of operational playbooks for 988. These are really intended for key stakeholders to assess what their needs are, and also have some resources available to help improve in certain areas. So if you go to NASHBID's website, you'll see playbooks for states and territories and tribes, crisis contact centers, PSAPs, and behavioral health providers. A huge shout out also to McKinsey, who had helped work with this project with NASHBID and SAMHSA, and all those really that engaged in this effort to provide content for those playbooks. So With that, I'll pass it over to Richard and see, Richard, do you have updates from 988 or 911?
Sure. Thanks, James. So let me mention three things quickly. So one, we're continuing to work on the mobile crisis $10 million availability that came to SAMHSA as part of the omnibus. We'll keep you informed about that. Secondly, there are multiple threads around 988, 911 activity. Would probably be worth having a focused presentation on the crisis jam on that. But in particular, let me mention in June, we will be having the Policy Academy for 5 states focused on 988, 911 collaboration. Those states are Maine, Georgia, Colorado, Minnesota, and California. And then the final thing, and this is actually a question for Lindsay. One of the things that we have really been looking at is, and as Sandy mentioned earlier, about how to enhance follow-up. And one of the things that's been successful, particularly in Colorado, also it's been utilized in New York, has been Medicaid hospital quality incentive payments. So anything more that we can learn about how those can be utilized would be great, because we know in the area of follow-up that it's a time of high risk. We know just what needs to be done. And the issue, as SAMHSA has said in an editorial in the Joint Commission publication, the issues are a diffusion of responsibility and lack of financial incentive. So any information on that would be great. And if you had some of that, Lindsay, it'd be wonderful.
Yeah, I'd be happy to brainstorm and talk more about some of those levers in Medicaid.
Sounds like a good opportunity for our CFO work group, Lindsay.
Yeah.
James, there was a question in the chat in terms of the timing of the playbooks, and you probably mentioned it. I just missed it, but when are you hoping to push those out?
Yeah, they are actually live now. And so you can get those off of NASHBID's website. And I think, Eitan, did we have a link from the SAMHSA website as well? I think you had mentioned that we do in our...
Yeah, I just posted it in the chat for everyone, which links to the overall partner toolkit, which includes the 4 operational playbooks, as well as a handful of other materials and documents that may be of help. So please look there.
Wonderful. And great news on the grants getting pushed out. I'm sure the states are waiting for those and more resources available for all this important work. So thanks for the update. Next, we'll hear from Megan. Megan, take it away.
All right. Well, I wanted to just reiterate about the playbooks and how excited we are about them. They, as James and Eitan said, they are on the NASHBID website. We'll put those links in the chat there. We are just so grateful for SAMHSA's leadership about the funding and the partner toolkit and the playbooks. It just has been a fantastic partnership. We really appreciate all of the partners that have worked on this, and they are out there. So we hope that these resources are helpful to the field and to each of the critical working groups that develop these playbooks. Thank you.
All right. And on the federal side, we are in recess, so there's not a lot of updates in terms of what's happening at the federal level, which takes us to our states update. So Jordan, Steph.
Yeah, thanks so much, Tom. Mostly just tracking some budgetary measures. Just this past week, Illinois finalized their budget, appropriating about $5 million for 988 implementation. I'll let Steph cover the rest and also talk a little bit about the survey.
Yeah, thanks, Jordan. A couple other spending bills just to mention. Vermont House Bill 740, that's heading towards passage. That would require their State Department of Mental Health to expand their mobile crisis team services based on some findings of their CMS mobile crisis team planning grant. Also in Alabama, Senate Bill 106, that their budget bill has passed their legislature. That has a $5 million set aside for a kids mobile crisis team program and $36 million set aside for crisis center funding. And I also, as Jordan mentioned, wanted to talk about a survey that we have open until the end of the week. We have a couple weeks ago on our 988 State Advocates monthly call, we had a great discussion on some of the bigger picture challenges that folks are having at the state level in messaging their 988 legislation, particularly around funding. So to follow up on that, we pulled together a brief survey asking on some of those common challenges and what kind of talking points that advocates would benefit from having stronger messaging support. So let me put that survey in the chat right now. Would love for folks to fill that out. Should only take 5 minutes. Again, that will be open through the end of the week. If you could take 5 minutes to fill that out, if you are active in your state on legislation. And that's the update from our end.
Thanks, Stephanie and Jordan. Great to see states continue to take action. And just a reminder for those states that have previously identified funding sources, have enacted legislation, there are these state cards that delineate information in terms of where that state is at, what they're doing with those resources, how that's rolling out. And so just more details in terms of taking that map and then really drilling down to be able to have more insight. And we'll continue to add to these cards as states take action. So look for additional detailed information on other states that have been enacting legislation that includes new resources. So Paul, David used to only give you 5 seconds, but I'm going to give you like 3 minutes in terms of if you want to chat about the calculator. You're on mute, Paul. And you owe $25.
That's very expensive, Tom, but I will eventually get it to you. So I'm sharing my screen now, and what I would love to do is just show how this reimagined calculator works. McKinsey and Company did this fantastic job of making it fully accessible. So what you're seeing here is just the calculator.crisisnow.com website. And once you get there, you just click in, use the calculator, pretty straightforward. It's going to pull out national data, and I'm going to pick a state. In this case, let's try Idaho. They have a lot going on in redesigning their crisis services. And what you're seeing right now is just the intensity or level of high needs of behavioral health that's seen in each of these counties. I could pick a county, and as you see, as I go through each one, I can select them. I can select multiple ones if I wanted to look at a regional approach. I'm going to leave it statewide at this point. And when I do that, I want to show you all how easy it is to edit the assumptions that are built into the calculator, the things that previously were sitting in a spreadsheet, pretty hard to find. And so here I'm going to say this data is actually informed. McKinsey and Company looked at the cost of inpatient care for individuals, and this would be based on commercial and Medicare payments. But let's say you're looking at your Medicaid payments as well, and you think this is going to drive the overall cost down to $1,200. You simply put the number in, and you can see how quickly our graphics change on the right based on that new information. I'm going to say the length of stay. Right now we have 368 reported here for total cost, but the length of stay we see is going to be 7 days now, we believe, and it quickly adjusts and changes. And I'm going to continue through. And I'm going to look at some of the assumptions. So what this says quickly, if I kept all other assumptions the same, is that we're going to need 23 mobile teams. We're going to need 96 short receiving chairs, 82 crisis short-term beds, 202 acute sort of inpatient beds that are available. But I can modify any of these things. And you'll see the assumptions. You just drop down. You can change any of these numbers as you wish. As an example, again, let's say we think our short-term beds are going to actually cost us even less than those acute inpatient, $1,000 per day for those 2 to 3 day length of stay acute sort of crisis beds. The chairs we're going to say are the exact same as the inpatient cost. Oops. And I'm going to say mobile teams don't cost us $270,000 to operate all year. These teams, we believe, going to cost us $310,000. So if I make those adjustments in here, all of the numbers start moving, and eventually I can do creative things like add a modified scenario. Let's say right now we can't do all of it. We're looking at prioritizing what we implement as a state in Idaho, and we're going to do these 23-hour crisis receiving centers. Look at this middle thing that built up, and mobile teams.
So, Paul, we are at the top of the hour, and I would encourage you. I would encourage you that you look at the chat. There was a question from Suzanne. There's a question from Kevin in terms of some of the assumptions. Suzanne's asking specifically around mobile response, and then Kevin was asking about what some of the assumptions are based upon in terms of the data. So I know that if for those of you that are interested, you can go back, and there was an entire presentation in terms of the updated calculator. So take a look at that where we dove deeply into it, but we'll dive into this in future discussions as well. Paul, thanks so much. And then thanks to Dr. Ford for your wonderful presentation and drawing the parallels and giving us the history of poison centers and just the evolution, just the tremendous work that's been done in terms of looking at data. Thank you all for joining the Crisis Jam. Until next week, take care.